Good morning, ladies and gentlemen. My name is Andrew Goodhart. Today I'll be presenting measles. So measles is caused by Measles morbillivirus. It's a single-stranded RNA virus that belongs to the morbillivirus genus. It goes by a few other names you may have seen in medical literature, include rubiola, morbilli, or English measles. Once you inhale the viral particles, the infection starts the respiratory lining. The virus uses hemagglutinin glycoproteins to target and attack macrophages and dendritic cells. When the dendritic cells travel to the lymph nodes, the virus hitches a ride. It invades lymphocytes and starts proliferating. From the lymphoid tissues, it spreads to the mouth, the tongue, and the skin. The most important thing to note is the virus destroys the memory T and B cells. This causes immune amnesia. Basically, the immune system forgets its previous training, which allows secondary infections to take hold. So what we have here is the clinical case definition according to the CDC. You'll see fever, rash, and one of the three C's, cough, coryza or runny nose, and conjunctivitis. The timeline of symptoms is as follows. So there's a wide range for incubation that can range from 6 to 21 days, typically an asymptomatic period. During the prodromal phase, you'll see a high fever, malaise, and diminished appetite. The illness phase, the acute phase, is where you really start to see the signatures measles symptoms, to include the Klopek spots, the maculopapular rash. You may also be able to palpate the cervical lymph nodes in the neck, and you'll see the conjunctivitis, coryza, runny nose, cough. Thankfully, for most patients, it fades after that. The symptoms diminish as the rash diminishes, and most patients will recover within 3 weeks from the start of the incubation period. And we'll discuss some of the serious complications later. So it's really important to do comprehensive testing. So we have a patient here with a viral exanthem rash. Do you have any guesses what it is? So this on the left we have roseola and parvovirus. So it's really important to be able to do comprehensive testing to rule out other viral conditions. So there's two ways we can do that. We can use serum IgM testing, which can capture enzyme immunoassays to diagnose from symptom onset. And we can also do reverse transcription polymerase chain reaction, which entails a throat nasal swab and can detect the virus after the onset of the rash. So as I mentioned before, measles is an extremely infectious disease that can be spread by airborne droplets. Each infected person can spread the disease up to 18 persons per day, and it's contagious with a window 4 days before and 4 days after symptoms occur. So as you may have heard, there was a significant outbreak in Texas in a religious community earlier this year. There were 776 positive cases. 94% were among unvaccinated or vaccination status unknown persons. And unfortunately, 2 children died. Before the vaccine came out in the 1960s, nearly all children got the measles virus. The CDC estimates this resulted in 48,000 hospitalizations, between 400 and 500 deaths annually. We started making headway against mortality on this disease before the vaccine. In 1941, the use of antibiotics to treat patients who developed secondary pneumonias had already reduced measles deaths by 71%. One intervention we can use in undervaccinated and unvaccinated populations is Gamestan. It's an intramuscular immunoglobulin that can be administered to measles immune naive patients within 3 to 6 days of exposure to positive measles contact, and it's good for up to 2 months. One of the serious complications of measles is called primary measles encephalitis. And basically, when the virus manages to cross the blood-brain barrier, it attacks the neurons and oligodendrocytes within the basal ganglia, thalamus, and cerebral cortex. This manifests as high fever, altered mental status, and in some cases, seizures and ataxia. This occurs in only about 1 out of 1,000 cases, but unfortunately, there is a significant fatality rate of 15%. The other serious condition, which thankfully also is rare, is called subacute sclerosing panencephalitis, or SSP. And this can present years or even decades after the initial infection. It's caused by defective proteins from the wild-type virus crossing the blood-brain barrier and infecting the occipital and parietal lobes. While the infection clears in the rest of the body, these malformed proteins continue to multiply in the neuronal tissue. We characterize this clinically by using MRI and EEG recordings. Ultimately, this can progress to fatal panencephalitis, which occurs in about every 3 to 11 out of 100,000 cases. While the vaccine is generally protective, cases have been observed in vaccinated children, and one of those is highlighted here in the weekly CDC report in Oregon in 2015. Another problem with encephalitis that we see is called measles and inclusion body encephalitis, or MIBE. This is a side effect associated with the live virus vaccine. With SSP, you have a similar problem that these not malignant bodies, but problematic bodies accumulate in the brain following a measles infection. The only difference is this occurs after a live virus vaccine infection, and the body can't clear it. This usually occurs in immunocompromised children. So thankfully, there is a vaccine. This vaccine was first started in 1954 when scientists isolated the strain from a boy named David Edmondson at the Boston Children's Hospital. They conducted trials in the 1960s that had some ethical lapses, but they were able to license a vaccine in 1963. Unfortunately, that wasn't as effective as they wanted and had a nasty side effect called atypical measles. So they revised it and changed it to a live virus vaccine by passing it through chicken embryo cells. And then after that, the MMR came out in 1971 that added additional live viruses. And then finally in 2004, they added varicella to give us the MMRV vaccine that we know and love today. So one thing the World Health Organization suggests for patients both in the first and third world, if they happen to get sick, is the vitamin A dosage. And they believe, according to their research, that they can reduce mortality and morbidity significantly. And this stat comes from a meta-analysis from the Food and Nutrition Bulletin Journal that looked at 8 different trials and found that vitamin A status can be protective in children. So thinking about measles as a future healthcare provider, there's a significant breakthrough rate. So it's critical for us to stay up to date in the protocols for both vaccinated and unvaccinated patients. We need to be vigilant as we encounter patients who could have problems from infections that occurred decades ago. One thing that needs more attention is research into the antiviral root one study in New York showed that it was well tolerated and was able to reverse measles pneumonia in several patients. We also need research into conditions like SSP and MIBE. There was a limited trial in India where a patient taking levamisole, an antiparasitic drug, showed complete remission. So there's lots of space in this problem set for additional research and additional treatments and interventions. I'll take your questions at this time. If there's no questions, thank you for coming to my presentation.